Hi and welcome to the Northumbria Maternity podcast. I'm Carla Anderson, Public Health Matron, and I'm delighted to welcome with us today Rae Lowe, who is the MNVP Chair for Northumbria. Today's episode focuses on shared decision making and the role of the MNVP. So welcome, Rae.
Thank you for having me.
Thank you for joining us. So the first question to get us started off then, so what is the MNVP?
Okay, so MNVP stands for Maternity and Neonatal Voices Partnership, which is a bit of a mouthful, but essentially we are a group of service users, so a group of women who have given birth, who have used maternity services in Northumbria, and we work together with the Trust to look at what that service should look like, to see how maternity services should be delivered, and just to listen to the women and the families that are using the service. So we're completely independent, so I'm not employed by the NHS, I'm not employed by the Trust, and that's good. That's really good because it means I can genuinely represent what I'm being told, and I don't need to worry about upsetting people. I mean, I do try to do it nicely and in a friendly way, but it does mean I've got that independence, so it gives a slightly different viewpoint.
Okay, so what is your specific role within the Trust of the MNVP?
I'm the lead, which probably sounds a little bit more important than it is, or certainly a little bit posher than it is. So I coordinate everything within Northumbria. I represent Northumbria in the bigger regional footprint across North East and North Cumbria. But it means I'm the person who goes to the meetings, and those meetings might be with professionals, so they might be with the midwives and the doctors, but it also means I go out and I talk to women, because what I need to do is make sure that the women and the birthing people, that their concerns and their worries and their feedback is aligned with what I'm saying in meetings. So I do that really regularly, and I literally just go out and have a chat with people. And on the whole, people give me really good feedback, and they often have nothing but positive things to say. But I'm also listening to the things, and sometimes they might be bigger things, but often they're sort of slightly smaller things, saying, well, it would be lovely if the food was a bit nicer, or it would be lovely if my children could come and visit at this time, or actually it'd be lovely if no one was allowed to visit me. So it's across all things. It's not just the big things, and it's not just the little things, it's everything. So I need to listen to the people using the services, so that when I do go in and say this is what service users want, this is what women and birthing people want, that I'm sure that I am actually representing things correctly.
Yeah, okay. So within the week then, because I know this isn't your only job, what does your week look like?
So we get funding for 1 day a week, and I'm lucky that I can work flexibly, and I don't have to dedicate a single day every week to that. I can work flexibly around that. So there's lots of different things I would do. So as I was saying before, the big part of that is going out and listening to women. So I go out to family hubs, I go out to parent and toddler groups, I go out to antenatal classes, and we have a big region, so I am working from Tyne up to the borders of Scotland, but I try to go out as much as I can. And then the flip side of that is looking at what I do with that information, and it's about I attend a lot of quite high level governance type meetings to work in a strategic way, to very much plan the services, so that when a decision maker in the Trust decides that they want to change maternity services in a certain way, I'm the person who can sit there and go, yes, but how does that work for women? How does that work for the service users? How does it work for their family? How does it work for the people actually giving birth? So, I don't know, for example, we would always want to be aware that the Northumbria Hospital is in Cramlington, but you're serving people who might be travelling down from Berwick. So if you've got someone who is pregnant and they need to have very regular appointments in Northumbria, in Cramlington, how would they travel up and down, and what impact might that have on them and their family, particularly if, for example, they don't have access to a private car. You know, how would they do? And it's looking at that kind of thing that at a higher level, the trust might not have considered. And it's just saying, but what about, how does that work in reality? And that's what we're trying to do. And if the changes are being made, and if there are suggestions, just constantly saying, but what about the woman? What about the family? What about the birthing person?
So literally being that voice.
Being the annoying person in the room who says, but stop, wait, you've forgotten this.
But so really important.
Yeah, because and just reminding people constantly that the most important person is the person who's having the baby.
Absolutely. Yeah.
And, you know, it's really important to make sure that the workforce is supported and that the rotas work for them and all of that. But you're the person having the baby. And that's why we're here. That's why all of us have come into this job, is to support that person and that pregnant woman. So, yeah.
Definitely. So if a woman is, I think you said Berwick or in Hexham, so she isn't near NSEC or Northumbria Hospital, how can she ensure that her voice is heard? Have you got a way to invite them?
We have, I listen in various different ways, and I try. It is just me and some other volunteers, so we have to box clever in how we reach people and how we listen to voices. So we have regular MNVP meetings, and we have those via Teams, and that does mean that anyone can come, and they might seem slightly more formal in some ways. So it is a meeting with an agenda, and we need to do that to prove that we are listening. But they're held on Teams, and anyone can come to those. And we have some lovely professionals that come along and talk about the services, the service provision that they're involved with, and asking for feedback. And then we ask service users to come along as well. Because it's on Teams, it's hopefully a little bit easier for people to come along. And we try and make them as family friendly as possible. So if people want to turn their microphone and camera off because they're looking after children, that's absolutely fine, and they can chip in when they want, or they can just listen. We love hearing people's birth stories and things like that, so because it just makes it real and it reminds us of why we're here. So if people want to come along literally to say, this is my birth story, this went really well, and I really enjoyed this, and I was really well looked after, but this could have improved things, that is exactly what we want to hear. So I'm always asking people to come along just to tell their story, essentially. So that's what we do from a more official side. And then from a more informal listening, I try to at least once a month go out to groups. So I'll go out to groups in family hubs, or I'll go to a baby massage class, and just rock up, and I'll say to people, tell me about your experiences, what went well, what could have been better. If you ruled the world, if you were in charge, what would you do? So if anyone is listening or watching this, and they have a baby group, a baby club, an antenatal class, a postnatal class, and they would like me to come along, then that's brilliant. Get in touch, and I can pretty much cross the whole of Northumbria. So that's the whole of North Tyneside and the whole of Northumberland. And it is really important. It is really important to hear lots of different voices as well. So if you've got a group that is for younger mothers or older mothers, or mothers who've had fertility treatment, or queer parents, or that kind of thing, then that's brilliant as well, because it means I really get to hear all voices, and that's really important. And that's why I tend to, as well as having our regular meetings, that's why I also want to go out and listen to those voices as well.
Great. So we can share the details of your Facebook page with this podcast.
Perfect.
But you have also got a group within Facebook that women can join, is
yes,
that right?
So we've got a public page where we talk about the things we do, we share information. And then we've got a smaller group, which is, for me, it's invaluable, because they're the people I go to when someone, if the head of midwifery might say, right, Rae, we are thinking of doing this. Can you get a little bit of feedback? I can go to them and say, how does this sound? What do you think of this? If we change the visiting guidelines from this to this, do you think that will work, or do you think it won't work? And it's also that group's really, really handy, because quite often I'm asked to put together questionnaires, and that's a really good way of gathering feedback from people. But before I actually put the questionnaire together, I might want to say to people, what do you want me to ask? I need to make sure I'm asking the right questions to get the right feedback. So if people wanted to join that group, it's a private group, as you said, and it's worth saying it's for service users only. So there's not any midwives there, there's not any doctors there, or more to the point, if they are there, they're there as parents themselves. They're not there in a professional capacity. So it's a very safe space to talk about the things that are working and the things that might need improvements.
Okay, thank you. When we talk about the kind of reason for this episode is shared decision making and your involvement and your support with that. So can you just explain from a service user, from a woman's point of view, what does shared decision making mean to you?
Okay, I think what in the olden days, which aren't actually that far ago, I know if I speak to my mum or grandma, for example, there used to be a feeling, didn't there, that if the doctor said you had to do something, you just sat there and you went, yes, doctor, of course, doctor, because the doctor knows best. I think what we're looking at now is very much looking at empowering women and birthing people to make the decisions that suit them best. Now, what's vital is that people have all the information to make an informed choice, and that they are supported to make an informed choice. So shared decision making is really looking at the different points throughout a pregnancy where information or choices need to be made, and making sure that those choices are presented as choices, not just a set pathway. And that's through everything, just making it really clear that everything is opt-in. So most people, when they're pregnant, know that they will be offered lots of blood tests, that they will be offered scans at certain points, and most people will accept those. But it is just making it really clear that actually, if you don't want to have a scan, you don't have to. These are the benefits of having a scan, but if you don't want to, you don't have to. And then particularly, I think when we get sort of later into pregnancy, the options and the shared decision making is often around birth. So from a really simple point of view, where do you want to have your baby? Do you want to have your baby at home? Do you want to have your baby in a midwife-led unit? Do you want to have your baby in a hospital? Even as far as which hospital, because what's important to you. You know, you choose your hospital because obviously in Northumbria we've got beautiful ensuite rooms, and it means your partner can stay, and that's lovely. And we've got car parking is relatively straightforward. That kind of thing. Or do you actually want to stay at home because you feel safer in your own home? Or do you want to have a water birth? Or you might want to have a water birth, therefore, do you want to go to a unit that you know has lots of birthing pools available? And it's that kind of thing. And often it's then looking at the complexities a woman might have, because we know that risk factors do come in, and that some pregnancies are more complicated. But the shared decision making is really important to support a woman, the birthing person and her family, in looking at what's important for them and how they assess risk, so that they have the information, but that the ultimate end decision is theirs. And that's everything. So that often around induction of labour, it's quite and the MNVP has worked with clinicians to put together a shared decision making tool, so that when women do get to a certain point in pregnancy, or if there are medical indications that an induction might be recommended, they can go into that knowing what the risks and the benefits are, and what the alternatives are, and what would happen if they decided to do nothing, and that they have all the information that they need. And it can be really hard, because I think sometimes things happen and you have to make a decision that you actually don't really want to make. But if you are supported and empowered to do that in a positive way, that psychologically just, you know, that really is empowering, and that's what we want to happen, that at the end of the pregnancy and at the end of the birth and at the end of the postnatal period, that you can look back and you can think, well, yeah, I was supported, and possibly it didn't quite go the way I was expecting it to, or quite the way I would have wanted it to go, but I know I was really well looked after and really supported throughout that process, and that's the gold standard, really.
You mentioned there that you supported the trust to make a shared decision-making tool. Can you just talk a little bit more about what that process was and your involvement in that?
So one of the things that I do is, whilst I listen to everyone's feedback, I then look at it thematically. So what I want to do is look at the themes that are coming out, and if lots of people are saying similar things, that's a bit of a flag that I need to escalate it, and I need to say, look, a few people have mentioned that this is an issue. So we were becoming aware of induction of labour, and that there was feedback that women didn't realise they had a choice, you know, that they were that the language used was around, oh, well, you are 40 weeks now, so I'm going to book you in, ring the hospital on this date and do this, rather than it actually being a genuine open discussion that at this point in your pregnancy, guidance says an induction should be offered because X, Y, and Z. So I worked with various professionals, and it was midwives and the obstetricians as well, and we were looking at putting together a decision-making tool, and it's almost in its very simplest form. It's a flow chart, and it says this is where you're at, you know, yes and no, but it's a checklist as well for the healthcare provider, so whether that's your midwife or your doctor, to check that they are giving you all the information you need, and a reminder to them that it's always an offer, but also looking at the types of information that women and birthing people need to make a genuinely informed choice. And then that is a tool that can literally be brought out at a moment when induction might be discussed, whether that's because of dates, whether that's because of other medical indications, if there's a concern that baby's not growing as well as it should be, for example. So that everyone's got the same information, and hopefully then consistently across the footprint of Northumbria, everyone who is discussing an induction gets the correct information, and it's presented in a way that makes it really clear that the choice remains with the woman and the birthing person. And it's hard, isn't it? Because I think some women want more of a steer, and some women actually want to be told, well, in my medical opinion, this is the best course of action. Other women want to go away and really think about it and make a decision that is right for them. Yeah. So it's very much looking at it like that, and also sort of then reminding the professionals as well that their view of risk might not be the same as the birthing person's view of risk, and that it's fine for a woman or a birthing person to make a decision that they're not happy with, because it's not their decision, it's the pregnant person's decision. And it's sort of working on both sides and empowering. I would genuinely say it's empowering everyone to really support the person who's having the baby to make the decision that's best for them. Does that answer that?
That's a great explanation. And I think you've literally said shared decision making. It's between the woman, the midwife, or the obstetrician.
Because, I mean, this is it, and I think most people will accept that the professionals, a midwife, an obstetrician, this is their area of expertise. They have links to the research, they know the national guidance, they know the local guidance, and they can go through that and explain why it's in place, and then support the woman to do what she wants to do or what they want to do, which may be in line with the guidance or may not, but they're making a decision from a place of information, informed choice, and that's what everyone wants. And also, I mean, this is the other thing I think, that known people can change their mind. So, and that they can go away and think about things. In most situations, I mean, there are some very emergency situations, but in most cases, it's fine to go away, discuss it, think about it, come back, and then change your mind if you want to. That's the other thing. You don't have to, mostly, you don't have to make a decision and that's it. And I think that reminding people of that is really important as well.
Good point. So you've obviously been involved in raising lots of issues and having a real voice within the trust. And as a non-clinical person, that might be tricky. How has that been for you?
It is really interesting because I think you do a certain amount of code switching because you do pick up the lingo when you're going to this number of meetings, but you do, it's something that's that I do when we co-produce things. So very often if there's new information that's been put together, new leaflets or new, you know, everything goes out on badger notes now, so it's electronic, and I'll be asked, can we have some service user input, can you read this? And I have to remind people that, you know, even if we're talking about things like cervixes dilating, what's the cervix and what's dilation? You know, and just reminding people that you don't, there's a whole language that goes with pregnancy and childbirth that people don't know. And that's even before you get to the whole language of medical stuff. And I think this is it. And I think especially for women in their first pregnancy, you know, all this information and all these abbreviations. I mean, EDD, and what's that? You know, estimated date of delivery, and what LMP, last monthly period. And of course, once you've even had one baby, you're inducted into that secret language. But when it's your first pregnancy, it can be really hard to do that. And so there's a lot of stuff we do around making that language accessible and the information accessible, because I can imagine that if you're sitting with, it can be quite intimidating, I imagine, that if you're sitting with, I don't know, a professor of X, Y, and Z, and he or she is telling you this, that, and the other, and you're sitting there thinking, I don't quite know what you mean, but I'm a bit too embarrassed to say that, so I'm just going to go, yes. And I think we've all done it a little bit. And I have to remind myself in meetings, for example, that it's fine to turn around and go, actually, I don't quite understand that. What does that mean? Why are you doing it? You know, if we're talking about a complexity and what's very complex and what's mildly complex from a medical point of view, for example, if we're talking about people with complex pregnancies. So that is, I mean, I've picked it up, but I try and constantly remind staff, and I think some are better than others, that not everyone comes from that medical background. So it is very much looking at that and just reminding people that actually, if we're talking about informed choices and decision-making tools and things like that, the language has got to be right, because you can't ask people to make a decision between X and Y if they don't actually understand what X and Y are, because the language you've used is so clinical that it doesn't actually make sense to a normal person.
You've explained that really well.
I hope I have.
You really have. That's great. So, and if a woman doesn't, or a family doesn't feel like they're being listened to, or they don't understand, like you've elaborated on that really well. So if they don't think they understand the information they're being given, or they're not being listened to, what can they do? What's your advice?
I mean, I would always say try and go back to your community midwife, because the community midwives I know are genuinely all lovely, and they've chosen to work in the community because they want to build up relationships with the women and the families that they're working with. However, I'm not completely naive, and I recognise that sometimes relationships do break down. So if that happens, there's several things they can do. The head of midwifery here is lovely. She's really, really open and would more than happily listen to anyone. Yeah. So I'd say go to her if you can. There's PALS as well, and I'm sure we can link afterwards to that. And they will take on sort of, I don't want to say complaints, but complaints if necessary, but also just concerns, and can help signpost. And always, 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 I'd say come back to us at the MNVP. So I know you've said we will link to that as well, because I always want to hear that feedback. And whether it's at the time, and it means I can signpost on, then that's brilliant. Or even if it's afterwards and you're looking back and thinking, oh, maybe I should have said something at the time, it's too late now. Well, it's not, because most people, often when I speak to people, what they say is, I don't want it to happen to anyone else. Yeah. And that's the kind of thing where we can really, really have an impact. So we can either take it on as an MNVP, or if it's an individual issue, I can really support that family to find the right avenue to change things, because everyone I work with in the trust, you know, they want the best for the people they're working with. Sometimes they get that wrong in the way they approach things, and then that's a learning opportunity for the staff. And then in the meantime, we have to work with that family to make sure they are getting the care that they deserve.
Yeah, absolutely. And is there anything else you want to discuss or when you have your moment?
I don't think so.
No?
Come to a meeting, get involved. Yeah. If you can't come to a meeting, send us an email, send us a message on social media, because we want to listen. Nothing's too big, nothing's too small, and we work with everyone. So that's the main message, I'd say. And if we don't hear that feedback, we can't improve.
That is a great point to end on. Thank you.
Okay.
And on behalf of maternity services and, you know, our women in the area, I think we're so lucky to have you being the voice for our women. You do such a great job.
I love my job. I love this. I've got 4 children, and I had 4 very, very different births, but I can honestly say that from all of them, I was so well looked after, and I came out of it feeling empowered, and everyone deserves that. Everyone will have a very different birth. Everyone's idea of a perfect birth will be very different, but however you give birth and whatever happens, you deserve to be supported and cared for with kindness and compassion, and that's my passion. So that's what I want to do. So, yeah.
That was a great point to end on. Thank you so much. Thank you.
Thank you for having me.